Good morning. Good morning.
Morning.
Steve Stites, Chief Medical Officer here at the University of Kansas Health System. I am here in the Dolph Simon studio where we are broadcasting related to our corona crisis. On my right is Hawkeye, Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control. And on the left is Rick Coldry, a guest I'm proud to have back because he's one of the few people on the campus that makes me look like I have a lot of hair. Although, you lost your razor someplace. What happened?
I don't know.
Yeah, well, any mumble's the answer. Fred Plapp, Flip Plapp, one of our outstanding pathologists, is on the line this morning. Fred is the director of the chemical side of pathology, and that includes lab, and that includes testing. And his person who he turns to more often than any other, probably all of us turn to, is Rachel Leisman. Rachel is a PhD scientist here at KU who is in charge of our micro lab and is really in charge of testing. And there are always a lot of questions about testing. So we thought we would bring both Rachel and Fred on the line as well as Rick to help us with those. Fred, you out there?
I am.
Good deal. Rachel?
I'm here.
All right, how close was I on your last name, Rachel?
Pretty close. It's Leisman.
Leisman, okay, so I wasn't close at all. Excellent. All right, Dane, how are we doing this morning?
Yeah, we're pretty good. Again, we should note that I believe in Kansas, it was the highest single daily total diagnosis yesterday of cases. Here at the health system and at the hospital, we have currently 23 inpatients. 12 of those, however, are in the ICU. So we've had, I think, 69 discharges, 70 discharges of recovered patients. So that's a very good statistic.
Yeah, that is good. And Rick, how are we doing down in the lab?
I think we're doing a really amazing job, actually. Our capacity for testing has continued to go up and up. This week, Rachel tells me that after hard work from her and her team, we're finally going to bring online some additional high-speed testing equipment that was donated to our health system to try to help the Kansas City community. So I think that's incredibly exciting news.
And how high speed is it?
So, that is yet to be actually proven. The vendor says that we can do 2,000 a day. There's a little bit of manual handling and manipulation, and Rachel can speak to this, to actually process 2,000 individual nasopharyngeal swabs in a 24-hour period.
That's a lot of swabs.
That's a lot of swabs. So we need to look at our process and see what we can do to how high we can get it. But I think we get it 1,000 a day is what I've heard Rachel say. So hopefully I'm not over-promising on
Rachel, all right, talk to us. Coldry's up here trying to promise a lot. What can we really do?
Yeah, he was pretty close. I think the total time on the instrument for this newest assay is going to be around about 4 hours. But as Rick mentioned, there's quite a bit of processing that happens to these specimens before we actually get a result. So our current estimates right now are about 4 to 5 hours total time for these tests, for this new test. But we continue to look at ways to make this process more efficient. So we're going to do a bit of a slow ramp up, but we think we'll hit over 1,000 tests a day. I think is feasible for our lab in a couple weeks.
Yeah, that'd be awesome, and I think that would go a long way to helping out our area. That's great news.
That's right.
And we have a way of, I think, starting to prioritize how we're going to look at testing. Do you want to talk at all about that, Rick, or Rachel, or Fred, or anybody?
Rachel, Fred, you want to offer anything about testing priority?
I mean, so far we've been prioritizing inpatients and KU employees and first responders, emergency room patients, and now we're starting to branch out that would increase our capacity so we can start to help out some of the county health departments. And then we've been supporting the Indian Creek swab collection effort.
All important causes, and hopefully we'll have even greater capacity in the not-so-distant future. So, Dana, talk to us a little bit about this testing capacity and what that means as we start to reopen society.
Yeah, we all want to start to reopen, get back to some semblance of normal life, seeing our loved ones and our friends. Increasing testing capacity, we've heard this as being the crux of the matter for a long time now. We need to be able to identify acute cases as soon as possible so that we can take mitigation efforts to try and stop the spread of this disease. Certainly identifying acute cases, and it's difficult because we know that with this virus, number one, you can spread it when you are not having any symptoms, but when you do have symptoms, as soon as we can try and identify you, we can then take in procedures and protocols to really hopefully keep you home, keep you well, and keep other people around you well as well. Stop from spreading the disease.
Yeah, it is. There's some information that's coming out of Northeastern University, and it's not really reviewed, but and it hasn't been published or talking about it, that says that for every one patient that's been infected, there are 10,000 that have had the virus. If that's true, that has broad implications to infectious disease thinking and how we look at herd immunity and things like that across the country.
Yeah, and I think that goes to the overall insidiousness of this infection. Some people will get very ill. A lot of people probably will not get too ill, but some people may not have hardly any symptoms at all, especially children. But it's going to be important as we move forward to look at that. And I think one of the ways we can look at that is with the serology or the antibody tests. Right now, we are continuing, and Dr. Plapp and Dr. Leisman are continuing to monitor the latest data to validate these tests, make sure that they're accurate, so that if we are performing that test on you, we can accurately say whether or not you have had contact or infection with COVID. Because I think moving forward, that's going to be the way to go.
That's really going to be important. So Rachel, Fred, where are we on the antibody testing? I know everybody's curious about that. I am too. I ask Rick about this every day. He's not yet given me the answer I wanted to hear. Let me see if you guys can do better.
We're talking to some of our major vendors that we trust, like Roche Diagnostics, Abbott Diagnostics, Beckman, that we know have produced good serological tests in the past, and that we'll be able to validate their testing in our laboratory. And these are also tests that we have high-speed equipment for already in the laboratory. So it would just be a matter of getting the test kits in, validating them, and then being able to run through our normal automation line in the main laboratory. Rachel and I are both very leery of these point-of-care rapid kits that have been released to the market without any real oversight. Most of them are these little cartridges like a pregnancy test. They test for both IgG and IgM. We don't know anything about their sensitivity or specificity. There's really very limited data out there, and I'm afraid they're going to have a lot of cross-reactivity with normal coronaviruses and give people a false sense of assurance that they're immune. And that's the other big thing about these tests is we don't know just because you have antibody really means that you're immune. And Rachel probably could elaborate on that some more.
So Rachel, I know you and your team have spent hours and hours and hours and hours and hours, that can go on for a while, go on for hours, about how many hours that you guys have spent working on the equipment in the lab. Talk a little bit about what it means to have to standardize that equipment and what you think is going to be required for this IgM and IgG test to really mean something.
Yeah, most of our testing and our work right now has been focused on our molecular assays, and that really is how we do acute diagnosis of all of our respiratory viruses. So this is similar to how we, would diagnose flu virus in a normal flu season. But one of the challenges for this lab really has been building this capacity. In order to do that and to deal with a lot of our supply chain issues, we've brought up kind of multiple different platforms or types of tests to run these assays. And logistically, that's very challenging. It's a little bit outside of normally how we function. And so we've done a lot of work to make sure we continue to report out very high quality results. And we plan on doing the same thing when we evaluate these antibody assays, as Fred mentioned. Looking at a lot of our vendors, digging really into the data, we are already thinking about how we would evaluate these assays when we bring them in. So then are at a point where we're giving results out, we're very confident that these results are accurate and they're reproducible, high quality standards.
All right. Well, thank you for all the work that you do.
And I would like to add too. Dr. Leisman has been with us since day one on this and has put in
hours and hours and hours.
14, 16 hours on a Saturday, Sunday. These tests are not simple. It's not putting something in the microwave and pushing express cook for 1 minute. These tests are complex, and she has trained her team because there can be a lot of human error in this as well. And so the whole team is trained to be able to extract the sample and produce it and analyze it in the correct way as well.
One of the rules used to use when up as an ICU staff member for a long time was you got to know what you don't know, and if you don't know what you don't know, you make a lot of mistakes. And the good thing about Rachel and her team is they know what they're doing, and that's what you want when it comes to lab testing. So, well, good morning out there. What questions do you have?
This is Mike Sherry with KSPT. I mean, you've talked about the hierarchy of testing. But how do you start going out and, I mean, given the fact that these point of these drive-by ones aren't very good, how do you ramp up to sort of the general public? I mean, and start just being out in the public for folks who are sick or been around people who've been sick?
Yeah, let me clarify one thing. So there are the drive-by clinics in which people are doing swabs. We have some, St. Luke's has some, Shawnee Mission, there are a lot, HCA, a lot of people have those. Those are good. Those are good labs doing good tests. Then there are the ones you can now that I think LabCorp has that are going to people's homes, and you can buy and do it at home, and or you can go down to CVS pick it up. The problem is we don't know what that test means, because it may as well be picking up another coronavirus, because there are many coronaviruses, as SARS-CoV-2. So I think the key is well, first of all, you just got to be in the hands of somebody who knows what they're doing, because you heard Rachel, you heard Fred talk about how important it is to make sure you have the right quality control. You don't want to, it's like buying a new car. If you have a new car that's got really bad quality control and it breaks down all the time and you get in a wreck, well, what good did that do you? You need to have really good quality control, Rick, to make sure that this stuff is done right.
No, I think that's exactly right. And, everybody, Rachel has taught me a ton about molecular microbiology. I'm going to get my junior badge here, I think, here pretty soon from her. But
Rachel, is that true? Does he get his merit badge or not?
He's done quite well, but we're going to give him a sash instead of a badge.
Excellent plan. That's what I would have said too.
Most people couldn't carry that off, but I think I can. To answer your question about getting testing into the community, so one thing that our lab has done, we were one of the first hospitals in the city to bring the assay to our lab. We focus on testing, as Fred, Dr. Plapp had mentioned, but with this equipment that Rachel's been working hard to bring online, our real focus is to bring testing to the community and to Kansas City. So the way we have started doing that is we are partnering with the local county health departments and also a federally qualifying health center here in Wyandotte County to get swabs in their hands. We're providing the materials, the swabs, and the media, and then we're also providing the testing. And so that's one of the things that we're trying to do to commit to getting Kansas City back to where we need it.
And I'd like to add, too, I believe the drive through and the community outreach ones, especially like Truman are doing, I believe those are still the molecular tests, the PCR tests, as opposed to the serology or the antibody test, as Dr. Plapp was discussing.
And you do have to distinguish between that. We heard one hospital in Kansas that was doing 1,500 tests a day with a 1.5 hour turnaround. We're like, it can't be the PCR test. And it turned out it was the antibody testing, and that's really not. The data around that is not strong.
That's right.
Yeah, and that concerns us because it create a false sense of, as Dana pointed out, a false sense of security. Other questions?
I have one this morning about, this is Taylor, Channel 41. There's apparently a new bit of human testing for a new potential thing going on in the UK today on a new vaccine potentially for coronavirus. Do you know anything about that? Have you learned anything about that? What could possibly be going on now?
Hawkeye is shaking his head yes.
Yeah, I know there's also vaccine trials going on in the U.S. I don't know a lot of details about that. I believe the one in the U.K. is an adenovirus vector. And so when you have an adenovirus, a virus, usually they are putting genes from the other virus that we're looking at, particularly COVID in this case, into that adenovirus vector, and then they would inject or somehow get the virus into your system. What they want you to do is then your cells to make special parts or proteins of the COVID, and then you can react to that. Those are the little bit of details that I'm aware of. They haven't put too much out. Most of it has been news reports. We've seen other attempts at adenovirus vector vaccination in the past. The first step, though, is just to make sure it's safe, and I think that's the phase 1 trial that they're going through at this point.
Yeah, you have to establish safety.
Yep.
Then you have to kind of get the dosing right, and then you have to go ahead and see if it's if it's efficacious.
And they were thinking about ramping up the phase 3 to the fall of 2020. So that's a pretty quick time frame as far as drug or vaccination is.
Yeah, usually you're looking at a 2 or 3 year timeline, and we're thinking it's shortened so much because of all the molecular abilities within medicine now and within people like Rachel and Fred Plapp. So, that's right. All right, other questions?
Hi, it's Cindy from KCPD5.
Good morning.
Hi. So another part of this, of course, is getting things back is contact tracing.
Yes.
Can you tell me a little bit about how that works exactly and how important it really is?
Well, I can tell. I'm going to take the easy part of that question. It is incredibly important because if you really want to keep society safe when things reopen, you have to make sure that you're doing those things that are going to try to replace what we are accomplishing with shelter at home. Remember, shelter at home is really a way to keep folks safe. And Kansas City we bent the curve, right? We've bent the curve. But when you reopen, this virus is so transmissible, it could really cause a real surge. Because we haven't had a real surge. We've had an increase in cases. We've had more deaths. No question about that. But we are not anywhere near like what happened in New York or Seattle. That could change rapidly as this virus takes off. So you have to be able to do contact tracing, Dana.
Yeah, absolutely. And we talked about this before. Hand washing and contact tracing are really two of the basic pillars of infection prevention and public health.
So talk to us a little bit about what contact tracing is and how does that work?
So the biggest part is to identify a case. After a case is identified, then there's an extensive interview asking where have you been, who have you been in contact with, who do we need to contact to monitor for new symptoms or test. And that is done by public health agencies every day. Obviously, we heard Dr. Norman talk about hiring 400 new people in the state of Kansas to do contact tracing. So hopefully we can get that ramped up as well. And that will be an important part moving forward of mitigation or containment of COVID. And
it really means just what it says, right? Mm-hmm. Somebody has to be on the phone contacting the person who you've come in contact with if you're positive for SARS-CoV-2. And so that's a lot of phone calls potentially. And one person can come in contact, especially when you open society with 20 people or 100 people. You got to call all those people, and that just takes a lot of people making phone calls. And fortunately, like for example, I know the School of Medicine here has volunteered some of the medical students. I know our school, that the health system has volunteered some of our team that may not be as busy right now because we closed down so many things to go out and work and work with the KDHE, and I believe others have done that as well. So it's a really important base concept of infection control. But don't forget, you have to do the things that we know that are right. So, Logan, do you have my little graphic I wanted to share with everybody today? All right, so Donna Clausen is over in the EVC. Shared this with me. It made me laugh out loud. But, it's a far side, and some of you may be too young to remember what far side is. But those of us who are not too young will know that we are missing Gary Larson every moment of every day. Where are you? Because this is a great time. We need some coronavirus humor. This graphic says it all, though, right? You walk out of the restaurant. Look, walks out of the bathroom. A little sign goes off. This man didn't wash his hands. Well, there's no social distancing. People are back at the table. They're back in the restaurant, and he didn't wash his hands. We need that. We need that sort of a sign to tell people you do or don't wash your hands because it's that important. If again, this virus is incredibly spreadable through just breathing, and so how do you prevent that? Well, when you're out in public, you wear a mask. you wash your hands, you don't touch your face, you cough into your elbow, and you do those, and you try and stay 6 feet away. That's what's going to help us continue to bend the curve, because shelter at home was a way to accomplish social distancing. And what we're trying to do now is open things up gradually, but in doing so, we have to maintain our physical distance and physical separation, because that's what's going to make a huge difference in our ability to mitigate the effects of spreading the virus too fast. So, okay. Come on back, Gary, anytime. Gary Larson, let's go. Next question.
Hi, this is Monica. Health System.
Go ahead.
I had a quick question. Somebody was asking, since an increase in testing will obviously result in more positive cases, would it be more useful to focus on a different number to truly know where we are on the curve?
Yeah, there are so many ways of judging where we are in a curve, and that's a lot of imperfect science, quite honestly, and especially because we've never attempted this with a pandemic before, even in 1918 or whatever with the Black Death and the influenza crisis. It was a whole different era of knowledge, and today this is the first time we've really hit a worldwide pandemic like this. So I think we're trying to learn so much about it as we do it. But I think, so we've been using hospitalizations or death as a marker for where we are on any given curve. Unless we're going to do broad-scale testing of everybody in the public, it's going to be hard to know how many folks are really infected. Even if we're doing 2,000 a day, that's not nearly enough if we really wanted to be able to go through the entire public and the entire population to know where we are. But every bit of information does help, Dana. So talk to us a little bit about how we can use some of that information.
Yeah, I agree. I think we need to look at, and we need to have our analysts look at this. But there are definitely ways that we can look at this. So total tests, yes, we can look at percentage of positive tests compared to percentage of negative tests. The total number of people getting tested, the number of hospitalizations, the number of deaths. There are so many numbers that we can use to look at this. And I think moving forward, those are the types of numbers that are currently being put into the projections. And there, as we had talked about before, there's a lot of projections, a lot of companies, institutions making projections. So just moving forward, we don't know exactly how that is going to change. But I think when we combine the acute infection testing, so the PCR testing, with valid serology testing, I think we're really going to have a better number of how many people.
Serology gives us IgM
and IgG, right? Yep, antibody testing.
Okay. Rick, anything else around that?
No, I think Rachel and Fred covered it really well. I don't think I can add anything aside from that.
All right. Other questions? I think one of the...
Yeah, this is Monica from Mytown Media.
Yeah. Hi, Monica.
Is there anything that people with pre-existing lung conditions, such as asthma or COPD, that may have tested positive or have symptoms and are waiting on test results can do to keep this virus from getting to an extreme level?
Yeah, great question. And that's yeah, I wish the answer was yes. But right now, the answer is we don't really know. And here's why. We don't have therapy. It's not like with influenza where you can take Tamiflu, and Tamiflu shortens the course and lessens the severity. We don't know that we have that drug right now. There may be some early trials and some early suggestions that remdesivir may be like that, but we just don't know, and it's nowhere near available enough. There are other possibilities that there will be drugs around it, but right now there aren't. So here's what you can do. Make sure you take your regular medications. Don't cut those out. People are going to be afraid, well, I shouldn't take my inhaled steroids. Well, yeah, actually you should, because you don't want to lose control of the underlying, of your base disease like asthma or COPD. And so the second thing you can do is make sure you get plenty of rest. And the third thing that you do is stay in touch with your physician's office to help monitor your condition. But there's no other real intervention. And without another intervention, it's hard to change how you're going to react to that infection. What we know is that most people, even with underlying chronic disease, actually do pretty well with SARS-CoV-2. But clearly, people who have COPD, diabetes, high blood pressure, heart disease, heart failure, cancer, are at a higher risk than someone who's healthy for having a more difficult course. And that's why you want to stay in touch with your healthcare providers in order to get to the hospital and get in and get care to support your conditions as best you can if you get sicker. But other than that, get some sleep, get some rest. I tell people to eat chicken noodle soup and take some vitamin C. But that's just my mom talking right there. It's not really medicine. And but no, truly, other than that, there's not a lot that you can do. But make sure you stay on your medicines and stay in touch with your healthcare provider.
And actually, I think there's actually good data for common upper respiratory and influenza that chicken soup does help. But as far as therapeutics goes,
really, my mom was right.
There's published peer-reviewed articles on chicken soup.
Yeah, you guys send those to me after this, because that way I can tell my patients.
Not for COVID, but certainly for other things, it can lessen severity as well. But as far as drugs and therapeutics goes, we are getting better studies here and better data. So certainly it might be more clear that certainly hydroxychloroquine plus azithromycin doesn't work. It can increase
probably bad news there.
Hydroxychloroquine, I think the jury is still out. Certainly the latest retrospective VA study would suggest not. But we still have the heroesresearch.org, the HERO study going on to look at prophylaxing if you've maybe exposed to it. So that's one other aspect. It's not treatment, it's called prophylaxis, maybe giving it to people prior, but we still need the information on that. And as far as the other therapeutics goes, one that's really getting a lot of press is the convalescent sera or the plasma or the antibodies. So, and I don't know if Logan has this. We are working on a trial with Mayo Clinic, and if anybody has been infected and has documented infection with COVID and wants to help, they are able to contact the Community Blood Center, CBC, and they can talk with them and work through and maybe donate plasma, because plasma may be a viable option. It might depend when we give it to you, early in your course versus late in your course, or things of that nature. That still has to be worked out. But certainly there are trials ongoing for that.
And we can do that here at KU as well as others people.
Yep, we will be doing it here. Yep, we have one of our lead researchers going on it right now.
I know Dr. Plapp has been actively involved with the Community Blood Center and convalescent sera in this trial that Dana is referring to.
So Fred, talk a little bit about that. Are we ready to go?
Next week, I think they're recruiting donors right now. We should have our first units next week. A person that has recovered from the illness and is symptom-free can donate plasma. It's actually collected by apheresis, so they can actually collect 3 units of convalescent plasma at one time.
And does that hurt the patient who's giving the plasma?
What's that?
Does that ever hurt the patient who's giving the plasma? I'm just trying to allay fears about
there's really no risk at all.
Your body can make those antibodies pretty darn fast, so it's really okay to donate some because you have plenty of reserve and plenty of ability to recover from that.
And we're only, you have 3 liters of plasma circulating, and we're only taking off 600 milliliters, so it's really, less than 20%, and it's really not significant.
Yeah. Good news. So encourage folks to think about that. If you feel like you've recovered from COVID-19, you've had a positive swab, and you're feeling better, then that can be a great way to help prevent other people from getting it. And just to make a quick comment, sometimes we throw around these medical terms, and to us they're we know what they mean, and sometimes we're not really sure. But that thing about the VA study and hydroxychloroquine is it was relatively small, because 163 patients or thereabouts, and it was a retrospective study. Retrospective means we look back, we ask a question of data. Hey, we gave some people hydroxychloroquine and we didn't give other people I wonder if how the people hydroxychloroquine did. The problem is there's a selection bias anytime you do that.
Right.
Because there's a reason some people got hydroxychloroquine and a reason some people didn't. But that's not how the study, it is not designed to answer the question about the reason. It's just designed to say, how do the people with hydroxychloroquine do? The only way to really study that is to do a forward trial, looking forward, a prospective study in which you say, I'm going to treat some with and some without, but we're going to match it up so they're really the same population. And that is a lot of times retrospective studies give you a clue, but they don't give you an answer. And the prospective studies are designed to give answers, and they often give answers that are different than the retrospective studies. So the real key will be how that prospective data turns out, like the HERO study. Really encourage healthcare workers to think about doing that, to take some hydroxychloroquine as they go, because they're all being exposed to COVID patients, to see if that makes a difference in our ability to prevent transmission. So a lot of words there. Happy to answer other questions about that sometime. Other questions that are out there. Did I just confuse everybody?
Hey, Dr. Stites, this is Nate again. There was a medical term or a term that was used earlier, an assay, and so people were asking what that was and what is PCR.
All right, Rachel, explain an assay to us. What is it?
An assay is just a fancy word for a test. Sorry.
So, in that fancy test you're doing with assay, what tell us a little bit about how it actually works. Because I think we've talked so much about testing, but once you get the swab in, what do you do with it? Do you kind of play with it? Do you show it under a camera, take pictures, send Instagram pictures? What do you do with those things?
Yeah, that's definitely what we do in the lab.
I thought so.
So, these specimens are first received in the lab, and we have to enter all of the specimen information into our lab system. So we get them into our computer tracking system, and there's a group of individuals that do that. And that's part of just our normal quality control, where we make sure the specimen is labeled correctly and has been transported correctly, and everything looks good. Because in the lab, we like to say garbage in, garbage out, so we kind of sure that we've gotten exactly what we're looking for to provide high quality tests. After that, the specimen, we have to change tubes because the original tube we have has this swab in it, and it's kind of hard to work around that swab. So we take the liquid out and put it in a new clean tube. We got a team of people that are doing that. And then it goes into our testing systems. So the first step that happens is we have to extract out the virus nucleic acid, so the virus RNA. And then after that, we put that into the PCR. And that's where we make lots and lots of copies of our gene target, and then we can detect that target. And that's how we know or can say if the virus has been detected or not detected in the initial sample. And then those results are all individually reviewed, and then they're released into our lab system and into the medical record.
It's really good, Rachel, to know that people like you and Fred spend hours upon this test and have worked their entire lives to achieve their excellent degrees, do an outstanding job, and the base philosophy is the same one my dad would have taught me when I was a young child. Garbage in, garbage out. That's important. Actually, it really is important.
It is important.
That's the key. Yeah. All right, other questions?
Yeah, Rachel had mentioned 4 or 5 hours. Does it take 4 or 5 hours to process one swab? Is that what you're saying?
Go ahead, Rachel.
Yeah, so we do them in batches for the most part. I mean, we have multiple assays going, but these kind of higher throughput, usually we can run about 94 specimens total. So in 4 or 5 hours, we would process all of those 94 specimens, and that would be the instrument time to get a result for 94 as a batch.
And just to be honest, and Rachel, one of the things that is so cool about she and her team is that they work so hard at this. So we do this test quality, and we make sure that if we rerun a specimen, that it has the same answer, and we do really well with that. And that's, I can't tell you how important that is, because that gives you the confidence in it. One of the questions we've had is, how come sensitivity of this testing has gone up to 95%? And it may be even higher than that. The answer isn't that the swabs got better. We use the same swab. It's that our ability to run the test is really high because you have good quality control. Again, garbage in, garbage out. But quality in, quality out. And that's what we see. And when we do these controls where we rerun swabs, we're like at 99.999% of the time that's the same answer, which is what you got to do when you're telling people something as important as you've had COVID or you haven't got COVID. Other questions?
Hi, Taylor, Channel 41 again. I had to step away from the call for a moment, so I apologize if this was covered. And it's a little bit non-COVID related, but I'm curious about other normal operation of the hospital, when people that are still waiting for maybe non-essential surgeries or that kind of thing can expect to be able to get back now that we're talking about things changing and possibly opening up again. What can people that are waiting on those kind of operations and surgeries expect?
You bet. That's a great question, Taylor, and it is important. One of the things we are concerned about is that people have been delaying care. So we know that across the community, really across the country, and this has been reported and talked about a lot, is that patients aren't seeking care for their chronic medical problems when things get worse because they're afraid. They're afraid to go to the doctor's office. They're afraid to go to an urgent care. They're afraid to go to the emergency room. They're afraid to go to the hospital. What we want to know, and we're going to talk about on Monday with some of our system leadership, is what we're doing to make sure that patients stay safe when things begin to accelerate. People have to have confidence that they are going to be okay when they go to a health system. And what I would say to you is if you're thinking it's okay to go to a grocery store, I guarantee you that we work harder than anyone, that is health systems in general, and I would say KU in particular, but certainly healthcare in general and hospitals and doctors. We work so hard at making sure that our patients stay safe and that our staff stay safe, because if they're not safe, we can't take care of folks. So we we talk about this every day for a couple of hours. Do we have the right PPE, et cetera? So we are putting things in place to make sure that as we begin to accelerate our care and people feel comfortable enough to come back to hospitals again, that we'll keep you safe. All the way from changing how we think about waiting rooms in the doctor's office. You may be sitting in your car and getting a text message, and you're not going to stop at the front desk anymore because we'll have done all that online. You'll go directly into a room, and then once you're in the room, you'll be greeted by a nurse and people in PPE, and then the physician, and then you'll head back out, and you won't stop at the front desk to make an appointment. You're going to go back out to your car, and we're going to call you and do a virtual scheduling of that appointment. I mean, there are things like that. We're going to slow down the operating room so we have time to make sure they're super clean in between cases and keeping everybody safe. I think everybody has been trying to work with the governor's offices in Kansas, and I'm talking about Kansas in particular now with KDHE and others, to think about when you can begin reopening and when it's not really reopening, it's to begin to accelerate the level of care that folks can give. And I think we'll have some important news coming out about that, and we'll talk about that and address that more specifically on Monday. But we're gearing up to go back and start opening up the cases. And the reason we can do that is we know that once we start doing more complex surgeries again, we're going to have more inpatients. We have more inpatients, we can't handle a surge as well. So you have to balance both sides, right? You want to open up and start taking care of people. I'm going to come back to a story in a minute. But we want to start taking care of patients and doing surgeries that we know need to be done. You know, we've held back on almost 3,000 surgeries now, so that's building quite a queue of patients who need to go ahead and get care. But at the same time, we want to make sure we don't go so much that we fill up every bed. Our normal census runs around 750, which is like 90-95% full. And then if there's a surge, we can't account for that as society reopens. That's the calculus we work on every day, and we'll continue to do that and monitor it. So I think you'll see more information coming out about that in the next week, and I think you'll hear our story about how we're trying to balance those two things together. Now for the story I wanted to tell you. There's pretty good information out there that people are having small heart attacks at home. Dr. Dendy was here a couple days ago and said the people having major heart attacks, they're still coming. Those numbers aren't really down. But the people having smaller heart attacks are probably thinking, well, I'll just let this nausea pass by. I'm a little sweaty. I'm okay. I'm a little more short of breath. Oh, I don't think I have COVID. I don't want to be checked. Or a little bit of chest pain, and maybe it's because I was out lifting some boxes. I don't want to. But the problem is that they're probably ignoring some of the signs of a small heart attack. And small heart attacks can be deadly. And so we're really nervous about what's going out in the community with folks who aren't getting some of the care they need, because there's pretty good early data that we're watching a rise in death from other causes now, and that's because people are afraid to get care. We have to establish the public trust that allows folks to understand that hospitals are safe, and we've done so many things to keep them safe. We built wards that were just keeping all the COVID patients in one part of the hospital. We're doing all the things around PPE, and we're redesigning how you get surgeries and how you get doctor's visits to keep you safe, because until there's vaccines, we are all going to live in a COVID world, and we can't stay closed forever. So we have to try and be open and do that to be as safe as we possibly can. And I guarantee you, and back to my guarantee, I guarantee you we will be safe.
And to your point, Dr. Stites, we had Dr. Lisbon on a week ago, and he was emphatic. You know, we have situations and protocols and systems in place through the ER to keep you safe. We have special rooms. Everybody is in PPE. You know, they want to see you if you are ill. We have those things in place, so please, if you're having those types of symptoms, you know, don't wait on it, because it could be very worse in the near future for you if you do not address it, if it is a heart attack or a stroke. So we have those systems and protocols in place to evaluate you safely and keep you and your family safe, and keep our healthcare workers safe as well.
One more thing, you know, we have those CMO calls you heard yesterday, and you heard a lot of folks on the phone. And I will just tell you that all of us are thinking the same thing. We are all working with places that want to keep their patients safe. Can you imagine a worse thing than having a hospital have a major outbreak because they weren't taking care of patients? And we can't do that. So I'll tell you, all of us in the community, all the hospitals, everybody, we're exchanging ideas constantly. How do we make sure we keep people safe? That was a long-winded answer to your very good question, but we wanted to make sure we tried to establish we wanted to work on that, because that's something you're going to hear a lot about next week, especially.
Well, and the heart attack thing was really interesting, too, so thank you for that.
You bet. Other questions?
Hi, this is Nate with the Health System again. I have a couple of really brief questions. One person was asking if Dewey is a location out in Hayes where people can donate plasma that you're aware of, and another person is wanting to know if we can say if we are working with any long-term care facilities to do any testing there.
Okay, we're going to cover those two questions. That'll probably finish us up today. So I'm going to ask Fred or Dana, do we know about what's going on around Hayes? Can people donate plasma out there? Or Rick?
I think most of the blood supply out in that area comes from the Wichita Red Cross, and they are collecting convalescent plasma.
So I think the answer would be yes then. You have to drive a little bit further to go get it. And then the second question, Nate, repeat that.
Long-term care.
Someone was asking if could you say if we were working with any of the long-term care facilities in the area to do testing? And
we are doing that, and we're working with that, I think, Rick, through the public, the county
that's right.
health departments.
The county health departments, they all have different strategies. I know that more than one of our county health departments here in the local Kansas City metro have an intentional strategy around going and testing in nursing homes and other areas where our most at-risk folks are collected.
As our KDHE. So, and if you see a county health official, they are working really hard. I'd say give them a hug. You can't do that right now, so you have to give them a virtual hug. So, hey, some of you may have questions that you want to send. You can send those to Medical News Network at kumc.edu. That's Medical News Network at kumc.edu. Tomorrow, Jessica Callender-Rich, who's one of our outstanding physicians, a geriatrician here at KU, and someone who's been appointed to the Wyandotte County Task Force looking at long-term care facilities, will be our guest, and we'll be really kind of gearing that show to what's going on in long-term care facilities, nursing homes, post-acute units, et cetera. So we'll invite your questions around that or any other topic that you have around coronavirus. So.
And Senator Moran.
Oh, thank you. I got her prompt. I should have said that. Our good friend Senator Jerry Moran will be back with us as well, because there are some additional aid packages coming out, and we wanted to visit with him. So, man, that's going to be a big morning tomorrow. Lots of good folks, and hopefully we'll have some good answers and some good information to share. But until then, remember what we always tell you. Rick, go ahead, please.
I would like to add one more thing. If any of my media friends are still out there, this is National Laboratory Professionals Week. So the physicians and scientists like Dr. Plapp and Rachel Eastman, who are here helping us make sure we have high quality testing, the technologists, the folks who draw blood, people who don't always see every day, they're kind of the unsung heroes. They're on the front lines in their own way. If you ask them every specimen, that swab that you provided at the drive-through swab clinic's not very exciting for you, but that is in fact you as their patient, and that's how they treat every specimen, every sample that comes into the laboratory. So if you have any way to recognize or thank or appreciate the lab folks who are on their own front lines helping us fight coronavirus this week, please reach out 24/7. That's right.
Thank you. That's an important shout out, and thank you for mentioning that. Dane, any last words of wisdom today?
Nope. Continue to wash your hands, and let's see what happens. We have Georgia opening up, and we'll see what happens with that.
Here we go. Good luck.
So
we keep saying there's no place like home, and even as we open up, remember that there's still no place like home. Stay safe out there.